Realize. Realize.
So,
Good evening, everyone.
Good evening, everyone. I
Anu,
think, Anu, will you start?
yes, ma'am. Good evening, everyone. I extend a warm welcome to each and every one of you for joining us today for the webinar. We are truly honored to have you with us. We have a lineup of exceptional chairpersons, panelists, and speakers who will share their perspectives on dry eye disease. So today's webinar promises to be insightful and engaging. I extend a heartfelt welcome to our esteemed chairpersons for graciously accepting the responsibility of steering the discussions today. We are privileged to have you grace the virtual stage. I would like to welcome Dr. Samar Basak Sir, Director, Disha Eye Hospital, Head of the Department Cornea, Medical Director, President, All India Ophthalmological Society, Dr. Namrata Sharma Ma'am, Professor, Cornea, Cataract and Refractive Services, Dr. R.P. Center for Ophthalmic Sciences, and Chairman, Scientific Committee, All India Ophthalmological Society. Dr. Rishi Mohan, Cornea, Cataract and Glaucoma and Refractive Surgeon at the Center for Sight at MMITech. I welcome you all.
Thank you. Thank you. I would request Dr. Samar Basak, the President of AIOS, to say a few words before we commence the program.
yeah, this is, thank you very much, Namrata, and thank you because of this common subject, and you are the organizer from AIS point of view. And as we are discussing that every day, all comprehensive ophthalmologists should learn dry eye diseases so that we get less dry eye patient. Because when a dry eye patient comes to you, we do not like to see those patients. So it is the time to share those patients among all, because we know that dry eye diseases has increased tremendously in current years, post-COVID, especially, and evaporative dry eye is, now it is almost 50 or 60% of the patients. So, and the molecules has changed since 2000, then DUSE 1, then DUSE 2, and then the recent other things, immunosuppressions. So there are a lot of opportunity to treat them. At the same time, it is a great burden for us. For all cornea people, especially, we get the patients at the late stage of the disease when probably sometimes we cannot do anything. So with this, so it is a great knowledge. All the brilliant speakers are there. We shared our thoughts earlier in many forums, and they will deliver the current views to solve these day-to-day problems. So what do you, Namrata?
Thank you so much, sir. Thank you for being with us today. And I'm sure we would have many insightful messages as far as the dry eye is concerned, which has always remained an enigma which is unsolved. And I would request Dr. Sharon to please please introduce the first speaker, and we'll begin the scientific deliberations.
Thank you, Dr. Namrata ma'am. I would like to welcome our very esteemed panelists for the evening, whose perspectives and experience are also going to add a lot of value as we explore the intricacies of dry eye. Our first panelist is Dr. Paras Mehta, who's a senior ophthalmologist and cornea specialist and head of Sameep Eye Hospital and Cornea Center at Vadodara. We also have Dr. Somshila Murthy, who is a senior ophthalmologist, cornea, uveitis, and ocular pathology specialist, and the medical director at the Shantilal Sangvi Eye Institute, Mumbai. And we have Dr. Rishi Swaroop, who is also a very senior and experienced cornea surgeon and heads the Swaroop Eye Center at Hyderabad. We are privileged to have all of them. And of course, we have a great lineup of speakers for the evening. And we extend our deepest gratitude to all of them who have joined us to share the knowledge and experience. Before we start the presentations, we want to remind everyone about it being a very interactive meeting. So throughout, if you have any questions, please use the chat feature and interact so that we can help clear all the queries. So without a further delay, let's dive into the dry eye disease, the Enigma solved. And our first speaker for the evening is Dr. Sayan Basu, who is the Professor D. Balasubramaniam Chair of Eye Research and the Director of Professor Brian Holden Eye Research Center and Director of Center of Ocular Regeneration at LV Prasad Eye Institute, Hyderabad. He's a clinician scientist and, of course, a key opinion leader in the field of cornea and ocular surface. Over to you, Dr. Sayan.
Thank you, Sharon, so much for the kind introduction. Thank you, Dr. Namrata, for the invitation and for AIOS for putting this together. So I'll quickly share my slides and get started. I'm going to talk very briefly on the approach to dry eye disease, and then we can have questions after that. So this is the algorithm that I use, and we at LV Prasad Eye Institute use to approach patients with suspected dry eye disease. So if you don't pay attention to any of the other slides that I'm going to present, this is the only one I think that is important and you can take home. So I call this the consider, confirm, categorize, characterize, and care algorithm. So you start off with, when do you think about patients with dry eye? So either the patient comes in with a complaint or is referred to you if you're a cornea specialist or an ocular surface specialist, or sometimes your retina or your glaucoma colleague will just send that patient over, see if the patient has dry eye because the patient is complaining, or in, when you're doing a preoperative evaluation, when you're about to do cataract and refractive surgery, because here, of course, the margin of error is small, particularly if you're doing premium cataract surgery. And typically, these are patients who complain of dryness. They'll say that eyes feel dry, or there's burning sensation, or foreign body sensation, irritation, grittiness. I have put in the subtext below, if you see, number one, which says that itching, typically, we don't consider it as a patient may be in the habit of rubbing their eyes, but typically itching, if the patient complains, you must think of allergy first, or other things like Demodex blepharitis, which is where it is more common and not a classic symptom of dry. How do you confirm? Confirmation, and I'll come to this in detail a little bit more, is essentially clinical. So you have symptoms and you also see some signs. So typically patients who have manifest dry eye disease will also have some amount of corneal fluorescent staining, and they will have a low breakup time. They may or may not have low Schirmer's, and I will discuss this in my next few slides. And a combination of these symptoms and signs will typically tell you that this is dry eye. If you do not have this combination, which means that you have only symptoms but you don't have signs, then you should think of neuropathic causes. If you have only signs but no symptoms, then you should think of neurotrophic causes. Okay, this is very important. So a patient with a neurotrophic cornea will have a lot of staining, but the patient will not complain of any sign. This is not dry eye, this is neurotrophic keratitis. A patient who has a lot of pain or other symptoms but does not show any signs in terms of low breakup time or corneal staining essentially has neuropathic condition. One of the common neuropathic conditions which resembles dry eye is called allodynia. So patients will often have cutaneous neuropathic pain or cutaneous allodynia. They'll complain of pain around the eye, especially on the skin on the eye, sometimes on exposure to wind or on moving the eye. They do not have dry eye. They have allodynia, which needs to be treated by a neurologist. So the next thing you do is categorize, which is basically you find out what is the gland which is primarily responsible. Is it the lacrimal gland, and does the patient have any signs of aqueous deficiency, or are these a manifestation of meibomian gland dysfunction, which is obviously more common. But if you diagnose the patient with evaporative dry eye, remember that meibomian gland dysfunction is not the only cause of evaporative dry eye. It can also be because of exposure. So do check for closure. Some of these patients may have lag of thalamus. Also ask for the history of nocturnal lag of thalamus, which they may not have noticed, and also examine the conjunctiva for signs of cicatrization, because they may have those things. So examination of the lids and the conjunctiva are important. We also we can examine the palpebral lobe, the lacrimal gland, to differentiate between aqueous deficiency and meibomian gland dysfunction. I'll come to this briefly. And once you have made this categorization, whether the patient they can be overlap, there often is overlap, but primarily has aqueous deficiency or evaporative, then you can treat based on the cause. So if the patient has aqueous deficiency, then you think of whether the patient has Sjogren's or cicatrizing. Sjogren's is most common, cicatrizing conjunctivitis is less common. Then you find the cause and treat. Most patients with Sjogren's will need immunosuppressive therapy from the rheumatologist because they may have either primary or secondary Sjogren's, which has other systemic manifestations. Those who have evaporative dry eye, it's primarily because of meibomian gland dysfunction, which is often related to screen time, but it may also be related to exposure, which you must rule out. All right. So if you really want to get a more, lot of practical advice on how to manage these conditions, I think AIOS and IGO did a fantastic job last year of publishing this dry eye special issue, which is the April issue of IGO in 2023. It has, I think, a fantastic collection of articles which are very practical. It talks about a lot of translational research, but a lot of clinical. The 3 articles that I would particularly recommend are these 3: the preferred practice pattern guidelines on aqueous deficient dry eye, on evaporative dry eye, also on the role of topical and systemic immunosuppression in dry eye disease. All right. So when I talked about signs, a common question that I'm asked is, what diagnostic equipment do general ophthalmologists require to diagnose dry eye? It doesn't matter if you're a general ophthalmologist or a cornea specialist. The only thing that you need to diagnose dry eye is a fluorescein strip. Okay, there is no other expensive or sophisticated paraphernalia that is required. That is only required in certain exceptional cases, or typically in non-responding cases, you might want to go for additional investigations. And we at LVPI or other academic institution use these for research. So if the patient has symptoms, if the patient has corneal fluorescein staining and has a low breakup time, then the patient has dry eye. These are the 3 basic tests. So the fluorescein strip is used for fluorescein staining as well as for the breakup time. If you can also do the breakup time using non-invasive techniques, but it's not mandatory. So you need nothing more than this. So why do I say only breakup time and not Schirmer's? Because if the Schirmer's is low, the breakup time is also low. Okay. And the breakup time is also low if the Schirmer's is normal, but the patient has evaporative dry eye. So the breakup time is much more sensitive for dry eye than Schirmer's. Schirmer's, the results are much more variable. If you don't do it in the right way, you can get variable results, and therefore it's not as dependent. So breakup time, if a low breakup time is always indicative of dry eye disease, the next step, of course, is to differentiate or find out the underlying cause. So where does imaging come in handy? Now, this is an example of a teacher who has high screen time, complaining of burning sensation in both eyes, has a little bit of staining near the limbus. Otherwise, the breakup time is low, the Schirmer's is normal. Patient has perfect vision. This patient obviously has evaporative dry eye, and you treat the patient as such. This is, typically how the meibography in a patient with evaporative dry eye because of MGD will look like. But meibography, in this particular case, will not really help you in the management. If you treat the meibomian gland dysfunction, the meibography will not change much, and therefore it's not really very useful. However, you can have patients who have exactly the same presentation, but an absence of meibomian glands. And there, meibography is useful because it helps you in differentiating patients who will respond to targeted therapy to the meibomian glands or not. So if you are, for example, prescribing or treating this patient with LipiFlow or IPL or Thermoflow or Mevoflow or any of these things, they will not respond to that therapy because the meibomian glands are gone. And it will be very frustrating for you, and the patient will be after your life. So this is where it comes in. Again, for meibography, no specialized equipment is required. If you have an autorefractor which has an infrared camera, you can do the meibography with that. There is nothing special about the meibography devices in more expensive dry eye equipment. So meibomian gland dysfunction is the most common cause of evaporative dry eye disease, as Dr. Samar Prasad mentioned. You know what to do in these cases: lubrication, blinking brakes, warm compresses, lid massage, rule out exposure. Before you advise these therapies, make sure the meibomian glands are present. And the conditions in which these glands are absent are those usually young females who are on some kind of hormonal therapy. This may be because of treatment for PCOD or for acne in young females. And for middle-aged females, it may be because of hormone replacement therapy. So that needs to be ruled out. I talked about the palpebral lobe of the lacrimal gland, which can be tested also using a fluorescein strip. Again, no fancy equipment required. You can just take an undiluted strip, touch it on the palpebral lobe of the lacrimal gland, see the egress of the aqueous component of the tear film, and you can very easily make out if the lacrimal gland is functioning normally or not. As soon as you touch it, you see these points lighten up. If this is very slow or the number of points usually between 3 and 5 are less, then you know that the patient has aqueous deficiency. So only caveat here is don't use topical anesthesia to do this test, because topical anesthesia itself reduces the reflex secretion from this gland. It is very useful in differentiating evaporative from aqueous deficient dry eye. Evaporative dry eye, the meibomian gland, in meibomian gland disease and evaporative dry eye, the lacrimal gland function is just like normal, and there is very rapid and brisk flow. Whereas in Sjogren's syndrome or cicatrizing conjunctivitis, which cause aqueous deficiency, the flow is very slow, the number of openings are less, and it's very easy to make this distinction. So when you have lacrimal gland dysfunction, you know it's either because of Sjogren's syndrome or cicatrizing conjunctivitis. You know the treatment, lubrication, anti-inflammatory therapy. Many of these patients who have underlying autoimmune disease will require a rheumatology consultation. But my only caveat here is do take the history of neurological medications, very commonly antidepressant sleeping pills, which might mimic aqueous deficient dry eye or a slow egress from the lacrimal gland because of the numbing of the reflex arc because of these neurological medications. So if the patients are on these medications, and that is the explanation, not that patients need to be taken off, but you need to tell the patient that, look, if you are depressed and you need antidepressants, you are going to have dry eye. So you also need to use lubricants. And the use of any topical medications, anti-glaucoma medications, which can cause what is known as drug-induced, ocular surface disease. So typically in a patient of aqueous deficiency, patient may have history of mouth or joint pains, may have a history of bone marrow transplant if they have GVHD, skin and mucous membrane involvement. Typically, the distribution of the SPKs are interpalpebral. If there is cicatrizing disease, so you need to look at conjunctival changes also. And these patients will have low tear meniscus height and low breakup time, low flow on DATS or direct assessment to tear function on lacrimal gland, and also low Sherman's. So this is typically how a patient with symptoms and sign of aqueous deficient dry eye will look like, interpalpebral SPKs. And this is if you investigate this patient, in this particular patient, the patient had rheumatoid arthritis and anti-CCP was positive. And also so this is basically a case of secondary Sjogren's syndrome. Patient will need to be treated for the rheumatoid arthritis in addition to receiving topical therapy. Now, this is a symptom this is a case where also you see, in addition to the symptoms, the patient also has interpalpebral SPKs, but the SPKs are very localized. You can see that in the on your left, it is localized to nasally. On your right, it is localized towards the superior inferior cornea and in the center. So this you might easily confuse as aqueous deficiency, which the patient does have, but there is something additional because you don't see the typical interpalpebral distribution like you saw in the other case. So here you need to invert the lids, which you need to do in every case, in fact, and you'll find that the areas of staining correspond to lid keratinization. This is a case of Stevens-Johnson syndrome. So not just a straightforward case of aqueous deficiency because of Sjogren's, but this is slightly different. This will require referring the patient to a cornea specialist. Cicatrizing conjunctivitis has many causes, and you can go through this article to look at how you can go about managing this case. But typically in practice, you will either see patients with SJS, or you will see patients with graft versus host disease, or you will see patients with pemphigoid or drug-induced cicatrizing conjunctivitis. Of these, I would say drug-induced cicatrizing conjunctivitis is on the rise because of the use of a lot of preserved medication in the Indian market. We have very few preservative-free combinations available. And this is something that is very easy to treat. In fact, the only form of dry eye which is completely reversible, because if you stop the offending medication, the ocular surface disease will stop. So in the dry eye issue of the IGO, which I mentioned in April of last year, we have a review on drug-induced dry eye, which you should go through, which will help you identify and treat these cases. You'll find this very useful. So typically, as you can see, on the top row is before, when the patient were using anti-glaucoma medication, which is one of the most common causes, but it can happen because of any preserved eye drops. And below, you have when those medications were withdrawn, you can see the improvement in the ocular surface disease. So you see here a lot of epithelial keratopathy, epithelial staining, which is gone, conjunctival inflammation, which is gone. And here the patient had, overall, you can see how inflamed the eye is. But after trabeculectomy and withdrawal of anti-glaucoma medications, the eye is quiet. So drug-induced dry eye is very common. It is more common than you think, and therefore please keep this in mind. And patients who are on medications, systemic or topical, which can cause this, please rule this out, because I am particularly emphasizing this because drug-induced dry eye is the only form of dry eye disease which is completely reversible. Meibomian gland dysfunction and evaporative dry eye is chronic. Aqueous deficiency because of underlying autoimmune disease is chronic. but drug-induced dry eye is completely preventable and reversible. So where drug withdrawal stops inflammation, progressive scarring, if we can correctly identify these cases, we can actually give the patients complete relief. So please look out for these conditions and take a proper history of all the medications that could cause dry eye disease. I will finish with this, that I feel that the diagnosis of dry eye disease is like diagnosing somebody with fever. So the fever, you will obviously treat them with paracetamol or an NSAID to reduce their body temperature. But just like giving paracetamol is not the treatment for dry eye disease, giving lubricants is not the treatment for dry eye disease. It is just a palliative thing that makes the patient more comfortable, unless you are able to, localize or essentially try to figure out what the underlying cause, the type, and therefore the cause of dry eye is. It is impossible to treat these patients satisfactorily. So I think I want to challenge this paradigm of dry eye, lubricants and topical anti-inflammatory being the treatment for dry eye disease. It is not. It is like giving paracetamol to a patient with fever. You need to understand why the patient has fever and therefore treat the underlying cause. And if you take this approach of trying to figure out if the patient has dry eye, what kind of dry eye the patient has, what is causing the dry eye, and therefore give the patient palliative treatment in addition to treatment to the cause, then and only then will you be able to really in a very comprehensive way able to address the patient's suffering and their symptoms. So treat the patient, treat the symptoms, collaborate with colleagues. You will need to collaborate with a rheumatologist if you're treating dry eye patients. But in general, try to figure out what is the type of dry eye and the cause, and try to treat the cause in addition to just treating the symptoms. I would like to thank, I'm very lucky to work with a very talented team of clinicians and scientists who helped me come up with all of these insights on dry eye disease. And, I want to acknowledge all of them. And, thank you so much for your attention.
Thank you, Dr. San, for an excellent talk where you very comprehensively showed us all the possible reasons for a person to present with dry eye and its possible masquerades. A very sort of a basic question to our panelists for the evening. There are a lot of tests that are done for dry eye. What, in your opinion, is the correct order to do these tests, whether it's the diagnostic tests or the basic tests that we have? Dr. Paras?
Hi, Sharon. This is a very basic question, but like if as Dr. Sayan said that you don't every time need to do a Schirmer's, as like fluorescein stain and T-Butt, and T-Butt would take care of everything. But still, if you were to do a Schirmer's, probably I would. In fact, before that, I would look at lower tier meniscus and corneal reflex, followed by other signs on the cornea, and then I would switch over to probably Schirmer's if I were to do a Schirmer's, and then the staining part of it. So that would be my order. And I mean, if you are suspecting the other elements, then maybe probably you can check the meibomian glands with infrared light.
And Dr. Rishi, if you could shed some light on, now that we have options for doing a non-invasive breakup time, is there any reason to prefer one over the other, or it doesn't matter because they're not always interchangeable? A fluorescein tear breakup time and a non-invasive breakup time.
So I think that there's really no major advantage of a non-invasive breakup time except that it's non-invasive. And I don't feel that the fluorescein staining is such an invasive thing to start with. So I feel that we should ideally we should just stick to that, because that becomes like one standard thing which we can do on every patient. Almost every patient who's having a slit lamp examination, you will stain before you do an applanation. So before you do that, you might as well just check for any staining and finish your T-Butt, and then go ahead and do anything else you need to do on the cornea, like an applanation.
Yes, and as we all agree, staining is such an important part of the evaluation in general. So anyway, we're going to put in the fluorescein stain. So great. Dr. Anu, shall we move to the next speaker?
I would like to.
So I have a question to Shayan. So
Yes, sir, please.
Shayan has actually omitted the rose Bengal stain. So what is the status of rose Bengal stain in your opinion?
Rose Bengal, sir, I don't use that often unless I am, trying to, my ocular surface practice, trying to rule out something like OSSN. Or what we used to use Rose Bengal also earlier for our research studies for conjunctival staining. Nowadays, we use lissamine green. So for all our research studies, we use lissamine green because it stains the conjunctiva better than fluorescein. We don't really use rose bengal that much. So I really don't know what the clinical, other than, where we have to rule out OSSN and we are using that to just to demonstrate the presence of keratin, which rose bengal stains very well. In my routine dry eye practice, I don't really use rose bengal.
How about lissamine green?
Lissamine we do use for all our studies because we also have to grade the conjunctival staining. With fluorescein, it's very difficult to grade the conjunctival. In general, I think lissamine green is a better stain than fluorescein. It's just that I don't know what the cost is. I'm very sorry. But fluorescein is just, fluorescein does the job. For, I think, routine clinical practice, fluorescein does the job. For those of us who are into clinical studies and all that, then you need to use lissamine. But lissamine is definitely a better stain if you are looking for the best stain among the three.
We can move to the next talk.
Yes.
I'd like to invite our next speaker, Dr. Himanshu Matalia, Medical Superintendent and Senior Consultant in Cornea Refractive Surgery and Ocular Surface Services, Narayan Nethralaya. He also heads the Stem Cell Research Laboratory of Narayan Nethralaya. Over to you, sir.
You and am I audible?
Yes.
Yes.
Yes, Himanshu.
And thank you, AIOS. Thank you, Dr. Namrata, for having this wonderful webinar and wonderful evening. So my job is to talk about 10 things which we commonly do wrong or we commit mistake while treating the dry or diagnosing the dry. Few of them Sayan has already touched up, so it will be sort of a re-emphasis on that. So starting from the first mistake, that's the classification of dry, whether it's dues where we classify the dry into aqueous deficient and evaporive or mixed dry eye, or whether it's Asia dry classification, dry disease classification by Asia Dry Society. They diagnose into aqueous, increase evaporation, and decrease wettability. All these things, whatever you see, are we actually classifying disease based on the root cause or its effect? The answer is simple. It's effect. We are not looking at the root cause. When we talk about dry eye, do you think all the dry eyes are same? Whether somebody who has a dry eye with rheumatoid arthritis, what San was showing, versus somebody who has dry eye with say simple MGD, do you think the dry eye is same in both of them? Well, of course, we know they are not same. It cannot be same because we are not looking at the root cause. Treating the root cause is absolutely must. Dry eye is an umbrella, and no two dry eye, what we are two discussing such kind of thing, they are not same disease. They are two different disease altogether. So when we are looking at sign of dry eye, which we are looking at here in most of our diagnostic, it's sign of damage. It's already damaged, and then we tell patients, sorry, we can't do much because it's already damaged and it's irreversible. So it's very important to find out what are the root causes and treat the root causes. Some of these dry eye, which are inflammatory dry eye, which we know that bone marrow transplant, autoimmune disease, RA, and all other things, where there is significant inflammation, we must start anti-inflammatory much earlier than waiting for the damage to occur. So it's very important to make sure that we treat the root cause and not the effect. The mistake number 2, that's something which Sayan touched up, that Schirmer's test without anesthesia, that too, which commonly people use it. Interestingly, if you look at the DUE's guideline for diagnostic test, the Schirmer's does not reflect here anywhere. The most important test which I love, which is fluorescent staining, whether it's staining the surface. And please remember, fluorescent staining without yellow filter, it does not tell you the entire story. Use yellow filter, which gives you the amazing thing which you normally would miss out on any other staining. So fluorescent staining, whether it's for TBUT or whether it's for staining, or even something interesting which it tells you, like your partial blinks. So when you're looking at somebody who is sitting in front of you on slit lamp, if you see these tide lines, which you can see in the central video, you can possibly see that the previous blink would have stopped somewhere where that means that was an incomplete blink, or whether it's a leg of thymus, which you can see while seeing the patient on slit lamp. So doing all such kind of thing does not take much time. Along with this thing, the Asia Dry Society also showed us very interesting thing about fluorescent breakup patterns. So different patterns can have a different leaning towards the diagnosis, though it may not be absolute, but it's certainly nice to look at the pattern of these fluorescents. So looking at the fluorescent stain itself tells you a lot of story about the dry eye. The mistake number 3, that's a frequency of lubricant drop. I don't know why ophthalmologists got stuck to this 4 times a day lubrication drop, which does not have any scientific logic there. Remember, there's something called ocular surface resident time. That's the amount of time a drop can stay on the ocular surface. Now, that depends on many things, from the rheological property to the blink rate, to the temperature, TFM clearance, pH, adsorption, evaporation rate, many things. Interestingly, long back from the group of AJ Brown, Anthony Brown's group in 92, they did a wonderful study on ocular surface resident time. And when they looked at direct and indirect methods, fluorophotometry and gamma scintigraphy, they found out that the half-life of thickest lubricant available that time, 0.2 sodium hyaluronate, was somewhere around 5.5 minutes. So even if you double it as a full life, 11 minutes, which does not occur, and you look at HPMC, their life is 44 seconds, not even a minute. So if you think about all such kind of thing, when you are giving a patient lubricant for 4 times in a day, in a waking hour of 17 hours, if they sleep for 7 hours, do you think it's enough for them? Of course not. Any lubricant which is given 4 times or less is more psychological. So ask them to use more rather than giving them a schedule. Tell them use it more when you need it more. So if during the hours when they need it more, possibly they should use it more. The mistake number 4, which is benzalkonium chloride. We love to hate this villain, and which is absolutely justified, that benzalkonium chloride is not the best preservative. But hey, you know that benzalkonium chloride in a normal case, when the TFM turnover is relatively normal, in 30 seconds, it gets diluted by 8-fold, and within 3 minutes, it's diluted by 36-fold, which hardly existing anything. However, when there are cases which already has surface toxicity, where there are multiple eye drops given or punctum occlusion, anything like that, of course, we would avoid that. But please do not worry. It's not as bad as we think. Mistake number 5, all lubricants must have all electrolytes. Now, when the company people come, they keep telling us about sodium, which is absolutely important for the osmolarity, potassium, which is needed for the goblet cell bicarbonate, which is needed for the preservation of corneal epithelium. Some of these things, like you look at the bicarbonate, which is highly unstable. In a multi-dose vial, when it's open, the bicarbonate does not stay there stable as the bicarbonate. It dissipates as carbon dioxide. Interestingly, one more example, like sodium. When sodium is combined with the carbomer, in fact, it becomes much worse. It reduces carbomer viscosity significantly. So just to add an isotonic solution along with the carbomer is not actually good. So adding everything together in one particular formulation is not best thing always. Mistake number 6. Higher viscosity, better the lubricant. Now, we don't have enough time to discuss about this particular thing, but we have thrown all these agents. And in fact, we are only spoken about viscoelastic agent in lubricant, and all the companies will tell you this is CMC, this is PVA, and whatever this thing. Interesting part, something like polyols. Now, interestingly, because CMC has come into price control, they all are coming back to throw all these agents to us. and with increased price rate. Like polyols do not have enough viscosity if it's not combined with HPGOR. So if anybody comes with such molecule and if it does not have HPGOR, it's not going to have enough viscosity. Please remember. Mistake number 7, not telling patient about refrigeration of your lubricant medication. Now, where does this come from? Well, the viscosity also depends on the temperature. Increase in the temperature reduces the viscosity significantly. If you look at all these charts, most certain agents like carmelos, hypermelos, they do not have enough viscosity in any temperature. So remember, simple thing like refrigerating the lubricant drop itself would maintain the viscosity. But how often we stress on this thing? We forget about the viscosity part of it. So please advise in Asian climate to refrigerate these lubricants. Mistake number 8. When we combine the medications like Cysteine Ultra or any similar medication with any other medication which is acidic, like aminoglycoside, cyclopentolate, what happens is the HPGOR, which comes into contact with an acidic pH, turns into actually liquid. It does not have viscosity. HPGOR is viscous when it's alkaline pH. So effectively, when you have co-use medications, something like cyclopentolate, something like antibiotics, effectively your ocular surface is acidic and their HPGOR would not have the viscosity, and effectively your lubricant drop would not work that. So typically, where does it happen? Well, it happens in microbial keratitis kind of cases. Now there, you don't want to give lubrication which is HPGOR based lubricants and which would actually not help. Mistake number 9, which is what Sayan also touched up upon, which is like MGD. Do you treat with LipiFlow warm compressed lid massage? Of course, we know that LipiFlow and warm compressed lid massage are the baseline of the treatment, but the meibography is something which is absolutely important. As Sayan was talking about, meibographers are plenty available. They are not very expensive, but if you do not have it, even for last almost a couple of decades, I used to use my simple, humble auto-refractometer as meibographer, and it absolutely works. The reason behind needing meibography is that when we do see an MGD case, we ask them to look for warm compressed lid massage and any treatment like say meibothermoflow or any meibomian gland expression. But when we do a meibography using any device, if the meibomian glands are present, we surely go ahead and do it. But if meibomian glands are absent, well, it's not going to work. And in such kind of cases, you might have to replace the lipid component. Not many components, not many lubricants are available with lipid component. But fortunately, few brands are there. And if nothing is there, we may have to resort to an ointment base. That also not many of them are available with us. Coming to the last part, where the mistake is we blindly follow that punctum plugs do not work. Interestingly, there's enough evidence out there which shows that punctum plugs do work, whether it's in terms of symptoms, in terms of sign, in terms of stability of tear film, it does have a better role. The more important part is sizing. The sizing of the punctum plug, if we do not do, we will end up dislodging punctum, either extruding out or it can dislodge inside. Sizing is not very difficult. All we need is punctum sizer, and which are plenty of them available in our market also. One such punctum sizer which I use, which has the punctum, which has the different sizer or probe diameter on both sides. One side is 0.8 millimeter. Now with 0.8 millimeter goes easily into the punctum. That means punctum is very wide. You need a large diameter punctum plug. If 0.6, which is on the other side, if we try to put, and if 0.6 does not go inside, it's a small puncta. You need to use small punctum plug there. So unless we look at the sizing, the punctum plug would not be accurate. Now, this is the flow which I would follow, where you decide about doing a punctum plug. Always do a sec syringing, lacrimal syringing. And if the syringing is not patent, avoid punctum plug. If the syringing is normal, and if you can surely try available, they are fine, and a patient is able to tolerate it, well, then you have a choice to either use an extended and temporary plug, which can work for almost 3 to 4 months time, and which is quite cost effective. We can use that, or we can use a permanent plug. If the person has significant dry eye and comorbidities like rheumatoid arthritis, we can go for punctum cautery also, and it reduces the aqueous egress and certainly works very well. Thank you very much.
Thank you, Dr. Himanshu. Very, very comprehensive and entertaining talk at the same time. And a lot of learnings about eye drops and so many things about dry eye that we usually tend to omit, including, as you said, the pH or temperature. So this is a question for you or any of our panelists who are here. How do you decide which of so many molecules that are available to us, is there any way to decide which molecule or teardrop you would prefer for a particular type of dry eye, or does it not matter? Or severity, for that matter? Dr. Somshila, if you're here, or Dr. Basak sir, Namrata ma'am.
Oh, this is a pretty old dilemma, basically, which molecule you will use. So there is a straight cut formula. If you go by Dew's classification and level 1, 2, 3, 4. So initially level 1 means milder type. So you can choose any type of lubricants. And naturally the cheaper one is better. The cheaper one is CMC based we have. Then according to severity, then you can use that novel preservative containing dry eye lubricants. Those are available and the frequency will increase. But then the question comes whether you will use the hyaluronate base or PEG based or HP Guar or oil emulsion. The Himanshu has rightly mentioned that in the evaporative dry eye we have to be more careful about selecting a lubricant there. We know right now we are having this system complete, but at the same time it is hugely expensive, and you have to consider that. And many of the times this evaporative dry eye are actually mixed type of dry eye. So frequency wise, that is again that contains polyquards, and polyquard you cannot, I mean, it is preferable not to use more than 6 times a day. So you have to combination of like CMC and systemic. And gel form is important for night application or the patient, and severe kind of dry eye, those are very important. But one thing I have noticed, and I'm practicing for a long time, that I always tell the patient that you keep all the lubricants in the fridge refrigerator in the lid, and it actually gives the better feeling. And at the same time, because of this, during this heat wave, you put a solution which is outside, it is equally temperature is 42, 43, you will not feel at all good. When I use myself drop, when I am in AC and putting the drop from the AC room into the eye, that makes a little different. And probably what Himanshu had told, that retention part of that particular lubricants will increase for few minutes at least. That is my perception, and I always take the experience from the patients. They always tell like that. So these are few suggestions. But one thing you have to consider always, that cost of dry eye disease treatment for 1 year more than a phacoemulsification surgery. And these people has many comorbidities also, like secondary Sjogren or other kind of disease, or patient is on antidepressants and others. So the medicine cost to the patient is hugely expensive. So dry eye disease is an expensive disease, and that you have to consider. So considering all these facts, so it is not that the disease itself is one side, and the patients and his ability to pay for dry eye disease treatment is also very. We write System Complete. Patient can afford only for 3-4 months only. Then he stopped. He goes back to other hospital and other consultant. They start with again CMC, etc., etc.
Thank you, sir. That was very beautifully put, both from the scientific point of view, and it's very important we understand the patient's point of view as well. If we have no further questions, our next speaker for this evening is none other than Dr. Namrata Sharma, who has very kindly helped us organize this webinar. She is the Professor of Cornea, Cataract and Refractive Center at RP Center for Ophthalmic Sciences, AIOS, New Delhi. And today she'll be speaking to us about the dual polymer advantage in the management of dry eyes. Over to you, ma'am.
Thank you so much, Sharon, for that kind introduction. And I am going to be speaking to you about dual polymer advantage in the management of dry eye. Dr. Basak sir very nicely summarized as to how we have to go about giving these medications, and what is the algorithm of the way we give these medications. So there are no financial interests to disclose, but as has been mentioned, that dry eye disease, there are a lot of people affected by it, and it impacts the quality of the life on those affected, and it is a huge economic burden as well for the patient. So 1 in 4 patients attending the ophthalmic clinics would report dry eye symptoms, and the prevalence of dry eye disease is high and ranges from 5 to 33% of the adult population worldwide. And there have been studies which have been done in India from our center as well as from LBPI, where the incidence is reported to be 16,482 per million population. The dry eye is seen. So this has been talked about, the various tests. Mandatory, of course, are fluorescein staining and tear breakup time, as well as Schirmer or any form of mammography that may be done. But there are other tests also which may be done more for research purposes rather than for diagnostic and therapeutic purposes. So this is the dues to recommendation and guidelines which have been given at step 1, step 2, step 3, and step 4, depending upon the severity of the dry eye. And it is important that the step 1 itself starts with the ocular lubricants, which are available and which are there and which are of various types. The lubricants remain the mainstay therapy for dry eye disease, although it has been very much emphasized that one should try to get at the root cause. But lubricants, fortunately or unfortunately, remain the mainstay therapy for dry eye disease and the first line of treatment, mainly because that is something which is available, and also mainly because that is something which is palliative. Now, which tear substitute to use? This is always a question. So in general, the algorithm is that for mild dry eye, you would use a 0.5% CMC or 0.3% HPMC or Carbomere. For moderate, you would use polyols with or without gelling agents. For severe, 1% CMC or hyaluronic acid with osmoprotectants. Now, when it doesn't get treated even by this, then I tend to combine 2 different tear substitutes from 2 different categories. And then, of course, one has to go totally preservative free, like Sir said, especially when the frequency becomes more than 4 to 6 times a day, and ointments and gels are required to cover the nighttime. Now, when do you change your drug? I generally would like to give at least 3 weeks to one drug to see whether it is acting or not acting, and then shift on to the next category. And if there is any evidence of inflammation, then I would like to add topical immunosuppressive agents as well. Now, there has been evolution of the tear substitutes in the various generations that we see. And it is pretty much the same that I had shown you in the previous slide. And of course, the latest thing is that artificial tears with the lipid component is also available, something which was not available earlier. And again, for all those who have a lipid layer abnormality, this can be given. Now, basically, the most commonly used viscosity enhancing agents would have polyvinyl alcohol or povidone, HPMC, CMC, and would have PEG or polyethylene glycol or sodium hyaluronate. But there are very few drugs who would actually have a combination of these. Our sponsors, that is Cipla, have come up with a combination of drug which has a combination of these drugs. And especially when HP guar comes in contact with the borate, it would lead to the formation of a matrix. And subsequently, this is something HP guar pH is important because it is pH sensitive at a higher pH of 7.8 in dry eye patients. It forms a reversible cross-link with the borate and results in the gel matrix with the mucin, and this gel layer spreads over the cornea and the conjunctiva. The portion of the HP guar polymer molecules, they bind preferentially to the hydrophobic sides of the damaged surface epithelium and essentially provide lubrication, retard tear film desiccation, enhance tear film stability, and serve as natural bandage to allow repair of the surface epithelium. Now, this is because of the pH gelling technology due to HP guar, it improves the retention time of the formulation and also provides increased relief from the symptoms of the dry eye. And it does have mucomimetic action also because of the mucin layer that is there and the maintenance of the tear film. And so it protects the corneal epithelial cells. Now, the fact that sodium hyaluronate is also present with it is important because this is something which is present in the connective tissue matrices of all vertebrate organisms. And again, lubricates and has lubricating properties. Then in eye, it is also present in vitreous and in lower concentrations, even in aqueous humor. And subsequently, it is a natural component of tears with proportion of that on ocular surface being synthesized by the corneal epithelial cells. So it does bind water and resists dehydration, promotes epithelial healing, and has viscoelastic property. And so it enhances the residence time of the drops which are present. And because of a large number of negative charges on the molecule, it has got great cationic holding large quantities of water. And so it lubricates the surrounding structures. And this is just to show how hyaluronic acid has a capacity. 1 gram of hyaluronic acid can hold as much as 6 liters of water. And so because of this, the evaporation of the water from the hyaluronic acid eye drops is slow and has beneficial effects and is much more prolonged. So it does promote wound healing because of the fibronectin, which is stimulated which is something which is stimulated to migrate, and it accelerates the corneal healing. And it also binds to the complex forms between the hyaluronic acid as well as the fibronectin, which enhances the wound closure and the wound healing. Now, this has already been talked about that you do need a viscoelastic property for the lubricant, and hyaluronic acid does have this viscoelastic property. And it helps in between the links, especially it forms a tangled meshwork, and the solution becomes less elastic and more viscous. And also because of this, there is increase, the tear film gets stabilized and the residence time of the solution on the surface is maximized. Now, when this PEG or polyethylene glycol along with HP guar and sodium hyaluronate, they combine together, then it forms a great combination because it provides increased lubrication, acts as a mucomimetic, accelerates corneal wound healing, and causes increased water retention due to the hygroscopic properties. And these effects which are present are synergistic on the ocular surface. So it is a dual polymer, and so it increases the tissue hydration and lubricity, and also protects the ocular surface from the damage, especially the desiccation which occurs of the epithelial cells. Because of this, the tear film stability is much better as compared to the other compounds, and the retention time is also much prolonged for this. Now, there are various studies which are available, which have looked at the effect of the PEG as well as the hyaluronic acid in the dry eye disease. And this is a study which looked at the combination and found that the tear breakup time after 60 minutes of installation was significantly increased. And this was done on 50 patients. Then subsequently, it was also found that it significantly improved the tear meniscus height within 60 minutes of its installation. And symptoms also improved when these were seen, as well as there was improved in the ocular discomfort post-cataract surgery, especially when the speed score was looked into. And this was found to be significant. There were 3 groups where the speed scores were evaluated, where one group where the HPG HA solution was given 3 times in the preoperative week and 2 months post-operatively. In group B, it was given only for 2 post-op months. And in group C, it was not used at all. So it was found to be, the results are found to be more superior when it was given preoperatively as well as in the post-operative period. Then likewise, the breakup time also showed a significant improvement in the group where this was used preoperatively and post-operatively as well. And there were effects which are seen also on the corneal epithelium. And there was protection against desiccation immediately after the treatment and after the formulation was rinsed away. And this was done in experimental studies. Now, again, this was to look at the recovery of the corneal epithelium in the tear solution. And this was done with the help of measuring the tear, which measures the integrity of the tight junction dynamics on the cell culture plates. And it was found that HP-GUAR and HA formulation exhibited a greater cell membrane barrier function than those which are associated with single polymer formulations. Likewise, for reepithelialization also in the in vivo cornea wound model, it was found to be efficacious, and this was done in animal model. And this group, as compared to the other groups, did the best, and this was found to be significant. And this is again to show the same. So to conclude, dual polymer tear substitutes provide increased tissue hydration, lubricity, and protect the ocular surface from damage associated with the dry eye. It helps in maintaining the tear film stability post-cataract surgery, provides significant greater cell viability than individual single polymer formulations on desiccated corneal epithelial cells, and helps in reepithelialization of the corneal wounds by accelerating the wound healing process. And this is the whole set of the dry eye portfolio from Cipla, the sponsors for this webinar, where they have all the range right from the CMC, the HPMC, the sodium hyaluronate eye drops, and the most recently the Flow Gel Hydra, which has both the polymers, that is sodium hyaluronate as well as the polyethylene glycol. So thank you very much for your kind attention.
Thank you, Dr. Namrata ma'am, for that lovely talk and a very interesting new molecule, which probably will have a lot of advantages and uses across. So one quick question to you or any of our esteemed panelists today. Of course, we are seeing now that obviously with a molecule which is dual, it can be used across different types of dry eye. What do you think would there be any use for conditions like recurrent corneal erosions or persistent epithelial defects where we need lubricants which will stay longer on the surface or have a dual action? Do you think it can also have some effect there?
So I think it would have effect there also, although there are no studies and people have not actually evaluated the role of the dual polymer on recurrent corneal erosions as well as persistent epithelial defects. Both of them are very difficult to treat and very difficult to tackle. So I think it remains to be seen, but I think we do need to do studies on with this polymer on those indications to see how it is going to work.
Great. Any comments from our panelist, Dr. Somshila, if you'd like to add anything regarding these drops, or where you think they would have a good use?
Can you hear me, Sharon?
Yes, ma'am. Yes, hi. You're audible, ma'am.
You're muted now, Somshila. We can't hear you. Somshila, we can't hear you.
I think she might be having a network issue.
Yeah.
Okay. Then maybe we will move to the next talk and take any questions or comments after this next talk. Our next speaker for the evening is Dr. Devang Angmo, who is the additional professor in glaucoma services at the RP Center, AIMS. And she has a lot of experience in dealing with glaucoma, of course, and patients with glaucoma who come back with dry eye. So she'll be talking to us on dry eye associated with anti-glaucoma medications. Over to you, Dr. Angmo.
Thank you, Dr. Sharon, for the kind introduction. Am I audible?
Yes. Yes.
Okay. So at the outset, so is the PowerPoint visible?
Yeah, Doctor,
Yeah.
can you make it on full screen?
Yeah, I've made it on the PowerPoint mode.
It's visible, please.
So yeah, at the outset, I would like to thank AIOS and Professor Namrata ma'am for giving me this opportunity. So I would be speaking of eyes associated with anti-glaucoma medications. So as we all know that glaucoma is a chronic progressive age-related degenerative disease, and whereas dry eyes, they have a multifactorial disease of the tears and ocular surface. And if you see, both of these are age-related causes. And if you look at the prevalence of the dry eye in various studies done in India as well as outside, the prevalence of dry eye is very high in patients of both patients of glaucoma who are on chronic treatment. So if you look on the ocular surface disease in glaucoma patients, if you look on the effect of polypharmacy and the preservatives, the studies show that ocular surface disease is common in those using topical anti-glaucoma medications, and there is abnormal tear film breakup time associated with an increasing number of eye drops, especially the BAK containing eye drops. And if you look at the impact of ocular surface disease treatment in patients with glaucoma, the prevalence of ocular surface disease symptoms was high in patients of glaucoma who were under chronic medical treatment. So if you look at patients, glaucoma patients, why are they predisposed to dry eye? Is because glaucoma is again a chronic progressive disease, more prevalent in the old age. And if you can see that the prevalence in ages more than 40 years is 0.3%, which increases to 3.3% in patients who are more than 70 years. They already, because they are it's an age-related cause, they already have a pre-existing poor ocular surface. These patients are chronically on topical anti-glaucoma medications, and mostly they have been using BAK preserved drops. And also the number of anti-glaucoma medications, they keep increasing from 3 to 4 to 5, depending to achieve target IOPs. And more importantly, many of these patients get operated and have glaucoma filtering glebs, or they have conjunctival chalasis, which again leads to ocular surface problems because of the immediate film breakup time. If you look at the effect of aging on dry eyes, so again with aging, there is basically lacrimal gland problems with aging. If you look at the ocular surface, again there's loss of blood cells with aging, and overall aging leads to a systemic pro-inflammatory state, leading to all these dry eye problems. So if you look, coming on to the anti-glaucoma medications per se, so there are different classes of drugs which have like the alpha agonist, like brimonidine. They have a very high incidence of ocular allergy. Nearly around 40% may develop ocular allergy during the course of the treatment, and they have a very bad ocular allergy if a patient gets so much so that we have to actually stop the medication and then start with the newer class of drug. The prostaglandin analogs, they cause obstructive meibomian gland dysfunction, but this is usually seen chronically when the drug has been used over a couple of years. And beta blockers, they not only reduce the basal tear turnover rate of the lacrimal gland, they reduce the basal and reflective tear secretions and lead to xerotic alterations in the conjunctival epithelium per se. So if you look at the effect of these drugs, the drug per se, the chemical itself leads to these problems. And also the BAK, which is the preservative used, the number of daily drops, the more the number of drops, more the side effects, and the chronic duration of treatment. All these leads to disruption of the tear film and ocular surface, leading to loss of goblet cells, meibomian gland, and accessory lacrimal gland function, leading to disruption of the corneal epithelial and reduction in corneal sensation, and ultimately leading to disruption of the tear film and thinning of the mucus, aqueous, and lipid layers of the tear film. If you look at the effect of long-term anti-glaucoma eye drops on conjunctival structures, an in vivo confocal microscopy study, it has shown that there was a significantly decreased goblet cell density and increase in dendritic cell density. A study done from our center also done on ocular surface evaluation in eyes with chronic glaucoma on long-term topical therapy. We also noted that there was a long-term topical anti-glaucoma therapy associated with decreased subnasal layer density. So commonly used preservative, if we see, is BAK. So BAK is the villain because it is a detergent action. It has a detergent action and dissolves cell walls and cell membranes. And we have other BAK-free preservatives like polycotinium, sodium oxychlorocomplex, SOC, sodium perborate, borate, etc. So if we look onto BAK, so it is the most common preservative, and because it has a detergent effect, it disrupts ocular surface and alters the corneal sensitivity. It leads to destabilization of goblet cells, and also it induces squamous metaplasia. So they have various publications in the literature where they show that ocular surface disease in glaucoma patients randomized to BAK containing latanoprost and preservative-free bimatoprost. It was shown that BAK containing latanoprost was associated with decreased tear secretion and may be associated with tear film instability. And ocular surface side effects should be considered when prescribing BAK containing medications. And if you look at another study to show the detrimental effect of preservatives in eyes of glaucoma patients on treatment, they showed an increased incidence of adverse events and have demonstrated that the preservatives reduce these side effects. So preservative-free anti-glaucoma drugs are clinically relevant or clinically beneficial for patients on long-term glaucoma therapy. So if we come on to the management approach, the main, if you look at is, first of all, is to minimize the effect of anti-glaucoma medications on the ocular surface. And second is, more importantly, is to recognize and then is to treat the ocular surface disease as at an early stage in the management course. So if you look, coming on to the glaucoma treatment, so preferably now one should use a BAK-free medication. Best is to use a totally preservative-free medication. And now a lot of companies are providing with preservative-free medication. The Cipla people are providing Zovatro PF and Primacom PF. And there are also preservative BAK sparing preservatives like SOC and perborate. And lastly, because these patients are on multiple medications, so a combination topical medication may minimize not only the number of drops, but also the preservative that are going into the eye, and thereby decreasing their side effects. So another study which shows that the efficacy, safety, and improved tolerability of BAK-free travoprost solution compared with BAK prostaglandin therapy. So it was seen that switching from BAK preserved bimatoprost to Sofzia preserved travoprost, it was noted there was an improvement in the OSDI score, decrease in the conjunctival hyperemia, and improvement in the visual acuity. Similar studies which have been done on other drugs, they have shown that a switch from preserved prostaglandin timolol combinations to preservative-free latanoprost improved not only the tolerability and optimized IOP control, but also provides better adherence with greater chances of treatment success. And also another study where preservative-free tafropros treatment leads to improved quality of life, increased patient satisfaction, and drop comfort. So, preservative-free formulations of glaucoma medications have become more popular due to improvement in ocular surface irritation induced by BAK. And a study by Jonan et al. Found that the pain during drop instillation, foreign body sensation, burning was significantly decreased after using a preservative-free beta blocker in comparison to a BAK-preserved cartiolol. So, our second prong of the management is to treat the ocular surface disease. So as various stalwarts have already spoken, where they have and has been discussed previously also, that preservative-free lubricants would be better in such eyes, and early intervention with ocular surface immune modulating such as cyclosporin or leftigras may also be helpful. And use of topical a study from our center has shown that use of topical cyclosporin for 6 months in chronic patients on chronic topical anti-glaucoma therapy, they showed a significant improvement in the subbasal nerve fiber layer and corneal sensitivity, and helps in reversing the adverse surface toxicity from preserved glaucoma medications. So this is a case wherein a 60-year-old patient with primary ankylosing glaucoma, right eye advanced, presented with the increased foreign body sensation and increased grittiness. And as we did the fluorescein breakup time, we can see that there was an immediate breakup and punctate epithelial staining. And on ocular surface analyzer, the NIBUT, it was definitely on the lower side. The lipid layer also was on the borderline side, and there was a meibomian gland loss much in the right eye, which was the advanced eye, and the patient was nearly on 3 or 4 topical medications, the right eye, as compared to the left eye, which only on 1 anti-glaucoma medication. And on LipiView, we can show that the average lipid thickness layer was definitely much lower in the right eye as compared to the left eye, which was on only 1 medication. So after giving the appropriate treatment, stopping the drugs and shifting the patients to preservative-free drugs and putting the patients on lubricants, we can see that there was an improvement in the tear film breakup time. Alternative treatment modality is that in patients who are intolerant to glaucoma medications or have very severe ocular surface disease, there we have to, the medications can no more longer be given, and the patient either may undergo laser trabeculoplasty, or they have to undergo surgical intervention to otherwise obviate the need of these medications. We have newer modalities that have come in, like in preservative-free, we have the Novelia drug delivery system. And in drugs like sustained release formulations, depot formulations like bimatoprost ocular insert, latanoprost and travoprost punctal pumps, and latroprost eluting contact lenses. They are in the pipeline. So another drug which has come is the prospective randomized single-masked parallel study, which is studying the effect of preservative-free ophthalmic solution containing hyaluronic acid and taurine amino acid on the ocular surface of glaucoma patients under multiple long chronic anti-glaucoma medication therapy. And they had included 39 patients, and they noted a significant improvement in the tear film breakup time of 15% over baseline, and increase in conjunctival globule cell density. And the addition of amino acids to the ocular surface lubrication seem to have an important component in the treatment of ocular surface disease related to glaucoma, as tau, it is the most abundant amino acid in the tear film. So the take-home message is that the coexistence of glaucoma and ocular surface disease is an important consideration for patients and ophthalmologists. Shifting to BAK-free anti-glaucoma medication is recommended, and more importantly, a preservative-free for improving the ocular surface related quality of life in these patients. Use of combination eye drops to be encouraged, and more importantly, the early identification and timely management of ocular surface disease is necessary. And especially these glaucoma patients who are on chronic anti-glaucoma therapy, they should be taught, or they should be counseled about the drug installation, that a single drug to be instilled in the lower fornix, and wiping of the extra overflow drops, and punctal occlusion immediately after the anti-glaucoma drug medication. And as Dr. Sayan had mentioned, that these drugs, especially right now in the very summer temperature, these drugs need to be refrigerated. Otherwise, the viscosity of the drug may also alter. Thank you for the patient listening.
Thank you very much, Dr. Devang, for a very, very comprehensive talk. I must say, during your talk, every time I was thinking of what possible questions to ask you, you seem to be answering it in the next slide. So that's wonderful. That's great. Question to you or any of our panelists. Dr. Somshila is here with us. Ma'am, if you could tell us that since we know that these medications can cause some toxicity to the surface or dry eye, is there any role of prophylactically starting the patients on any lubricating drops, or do we wait till they have any dry eye symptoms? And if so, any particular molecule is preferred, or do any of these molecules hamper or improve the AGM absorption? Is there anything like that? I think too many questions in one, but.
Thanks, Sharon. I just felt like, you were taking my exam or something. But jokes apart, no, this is a very important topic, actually. Thanks, Dr. Devang, for such a comprehensive coverage. And now I'm practicing in another place. So I guess I see a lot of patients who come in for just an eye examination and not just corneal cases. And quite a few patients seem to be on anti-glaucoma therapy where I'm practicing. And they come in with typical symptoms of irritation. They have some congestion. And for some reason, the drug they've started on is usually a single drug, which is a PG analog. So that's the first thing, that the recognition or the awareness that this medication is not really, it's not friendly to the surface at all. And ideally use anything else but this one. This is the wrong one to start with, if you can use some other medication. And apart from what Devang had covered so beautifully in her talk, she'd gone stepwise on how to change. If you have to use a particular drug, then what are the alternatives, like BAK-free medications available. Your question about should we use prophylactic lubricants, I would say no. Most of the time, by switching or changing, you're likely to affect, maybe during that time of conjunctival recovery, you might add lubricants, but prophylactically, it's, you're giving the disease and trying to, so it doesn't really help. We'll dilute the other drop anyway. About, do any lubricants block the efficacy of AGM? So I don't know the answer to that. I think that if you time them, if you have to use a lubricant and using AGMs, topical AGM, so maybe if you time them appropriately, I don't think that they should block the penetration of AGM. But definitely you can maximize the AGM by, how the glaucoma colleagues say that you put it in the eye and lock the punctum. So minimal drops, so you don't have to instill too many drops at a time. It's a complex topic, but most important is recognition that drugs can cause, even they can cause drug-induced DICC, and Anahita has published on that, drug-induced cicatrizing cheilitis, so has Bhaskar. And this is the most severe version of it. And sometimes, even when you withdraw the drug, the damage is done or the disease sort of perpetuates itself, perhaps. And then you can't withdraw from the damage that is done. So you have to recognize it early on. That's what I wanted to say.
Okay, thank you so much, ma'am. We'll move on to our next speaker.
I would like to invite our next speaker, Dr. Bhaskar Srinivasan, Senior Consultant in Cornea, Ocular Surface and Refractive Surgery, Director, Code Eye Care, Chennai. Over to you, sir.
Thank you. Just share my screen. Yeah, my screen is visible.
Yes, Bhaskar.
Yes.
So thanks, Dr. Namrata, and thanks AIOS for the opportunity. So I'll be talking about something which all of us as ophthalmologists face: cataract surgery and dry eye. No financial disclosures here. So basically, when you look at the DUES guideline itself, you look at asymptomatic patients, and when you examine them, they might have signs of an ocular surface disease. Either it could just be that they are very early in the disease phase and they are not symptomatic, or they could be having what we call as neurotrophic conditions. Now, it's important to recognize this, because once you go and operate these patients and then they get a worsening of their dry eye status, and they will blame it directly on the surgery. So when you're looking at a cataract surgery itself, and this was a study done in 2017 where they looked at the effect of dry eye on cataract surgeries. And what they found was that almost about 60% patients had preoperatively had a breakup of less than 5 seconds, and almost about 76% had some sort of positive staining on their surface, and about 50% had central corneal staining. And the Schirmer's less than 5 was seen in about 20% patients, and about 50% had a Schirmer score less than 10. So various parameters of dry eye is significantly present in most of our cataract patients. And just because they don't complain of it, if we don't stain and evaluate their ocular surface, we might miss these patients. And if they get a bit of discomfort post-surgery, and then it gets labeled as post-cataract surgery dry eye. How do we evaluate a dry eye? This has already been discussed. Obviously, you will have questionnaire. You will have to look at your various clinical investigations. You might have research tools that you can do to in an institute. But the most important probable aspect is the use of fluorescein, and this has already been mentioned. It's very important that all your cataract patients just use a drop of fluorescein, look at the ocular surface. You will see how much of corneal staining is there. Using a yellow filter, you'll be able to see the conjunctival staining also, so you probably don't need to use a second dye such as rose bengal or lissamine gray if you have the yellow filter in your slit lamp. And it is very important because it can affect your outcomes. So this patient who had a secondary Sjogren's and the dryness was not under control, went ahead with a cataract surgery elsewhere and ended up with a significantly compromised ocular surface post-operatively and a very unhappy patient. And then we had to address the dryness with a punctal occlusion to actually improve the vision and comfort of the patient. So you don't want to have an unhappy patient after doing an excellent phacoemulsification surgery. So when you're looking at cataract surgery, we all pride ourselves on hitting emmetropia. And if you have an imperfect ocular surface, your intraocular lens calculations, your toric IOL axis and magnitude, everything changes. And you might exclude patients who are suitable for a toric lens based on your erroneous keratometric values, or you might have a wrong IOL put. And that's a very difficult situation to face the patient subsequently then. Even when you're looking at a surgery itself, we do know that cataract surgery, refractive surgery, all do cause a change in the ocular surface milieu, and they lead to dry eye, and they aggravate existing dry eye symptoms. So cataract surgery can both induce a worsening in the pre-existing dry eye or can actually cause dry eye, and these can affect the outcome and quality of life in these patients. And the discomfort post-cataract surgery might really make the patients very, very uncomfortable. And if you're looking at type of surgeries, phacoemulsification, almost about 90% patients had dry eye at 1 week. And if you're looking at a slightly larger section in terms of an SICS, about 92% had dry eye post surgery at 1 week. So why does it occur? Basically, from an incision point of view, you have a denervation of the nerve, which could affect the epithelial healing. If your incision is not made correctly, that irregularity will again cause a discomfort to the patient. There is increased epithelial permeability, and there is also loss of cytoskeletal structures associated with cellular adhesion. So the corneal sensation is affected to a certain extent, and that can result in a decreased secretion and less blinking, leading to a dry eye disease. So when you're looking at a cataract surgery in a dry eye patient, your preoperative assessment is important. You need to assess the cause for the aqueous tear deficiency. And if there is a component of a Sjogren's in terms of a secondary Sjogren's, you would need to refer to a rheumatologist to make sure the disease is under control and plan the cataract surgery only when the disease is under remission. Emergency cataract surgery, if it has to be done in terms of a phacomorphic or a phacolytic glaucoma, you might want to cover it with systemic steroids. You would want to treat the aqueous tear deficiency as maximally as possible, improve the surface, and then plan cataract surgery. If there is significant MGD, you would want to correct it as best as possible before planning a cataract surgery. Intraoperatively, in certain situations, you might have to do a acanthotomy, especially in eyes with SJS or OCP. You might want to take lid sutures if the fornices are shallow. In terms of the normal cataract in, say, a Sjogren's or a secondary Sjogren's, the discussion is always on whether you would want a scleral incision versus a clear corneal incision. We don't have studies to say this is scleral is better or clear corneal is better. Each has their own advantages, but it is important to know that your incision should be as small as possible and there should not be any leak. If you feel there's even a slight doubt of leak, get on with it and take a single suture so that your incision is secure. Intraoperatively, you don't want desiccation, so you would coat the ocular surface with a viscoelastic. You would want to reduce the microscope illumination so that the toxicity of the light on the ocular surface is minimized as much as possible. Everything in the perioperative period you need to do to reduce the risk of epithelium breaking down. And if you have a severe dry eye and the epithelium is compromised, like in an SJS patient or an OCP patient, or you have to open up the fornix, your conjunctiva a little bit to access for your incisions in an SJS patient, you might want to combine it with an amniotic or a tarsorrhaphy, or if it's very severe dry eye, you might want to combine it with a cautery. Prudent to say, if it's a moderate to severe dry eye patient, you're not going to go ahead with a multifocal lens. So in general, you would want to limit the incisional damage. So you won't want an as small an incision as possible. So you would prefer to avoid astigmatic keratotomies as such. Between conventional phaco and flax, there seems to be a slightly higher risk of dry eye in flax because of the suction induced loss of goblet cells in those eyes. Perioperatively, it is important to avoid the use of NSAIDs as much as possible and to use preservative-free drops and to use as minimal drops as is required for that particular patient. Again, the use of topical anesthetic during the surgery can be minimized, but at the same time, you need to make the patient comfortable. Povidone we use to make sure that our surgery is safe, but you don't want to be using more than 1 drop of povidone in these eyes. So the cataract surgery can worsen various parameters of dry eye in terms of the Schirmer's, the tear breakup, the symptom scores. It worsens the fluorescein staining. It can reduce the goblet cell density. So it impacts all parameters as far as dry eye is concerned. And patient dissatisfaction is one thing that we all are worried about, because once we do a good surgery, we want the patient to be happy. We don't want the patient to sit at our chair and eat our chair time once we've done a good job. And dry eye is one of the most common discomfort that the patient complains to post-cataract surgery. So in your post-operative measures, you'll probably be looking at preservative-free antibiotics. If you're using a post-operative antibiotic regime, use of topical cyclosporin perioperatively, especially in patients with Sjogren's syndrome. You should be careful regarding tapering of your topical steroids. You need to be having a more closer follow-up of these patients as compared to your normal cataract patients. You would want to avoid NSAIDs as much as possible. For OCP, the patient might have to be on immunosuppression. For OCP, you would probably not want to make a conjunctival nick. You will definitely want a clear corneal incision. And if there is any epithelial defect in a patient with ocular surface disease post-cataract surgery, your treatment algorithm has to be much faster as compared to a normal patient. You have the other options of autoserum tears, platelet-rich growth factors, scleral lenses, which you can use perioperatively in select cases as such. So going through certain case examples, this patient gave a vague history of trauma with decreased vision, with a dry keratinized lackluster appearance. We couldn't really see much. The Schirmer's was 0. The surface was keratinized. Patient was having significant surface inflammation. So we said, okay, we'll just do a cautery and at least make it a little bit more moist so he's comfortable. And once we did the cautery, you can actually see how much the surface has improved. And now we were able to see that there's a cataract there. After this, we went ahead and did a cataract surgery and then gave the patient the option of using a Prose lens, and his vision improved from hand movements to 6/18. Another patient with Stevens-Johnson syndrome, where you will have to take it one step at a time, cautery for the dryness, MMG for the lid margin keratinization, followed with cataract surgery, followed by a Prose lens to improve their vision. Obviously, in these eyes, you might have to use light pipe for better visibility. Your IOL power calculations might be difficult because of the corneal scar. Another couple of patients where we had to do a patch graft and then did an ECC IOL. Sometimes where the visibility is very poor, you might have to go back to SICS or ECC also. Not all cases you will be able to do phacoemulsification only. And it's important to understand the disease and take one step at a time to reach your end goal of giving patient vision and making sure that the disease in terms of the dryness is under control. So to conclude, you assess dry eye before cataract surgery. Fluorescein plays a very important role in understanding the status of the ocular surface health. Improve the ocular surface before cataract surgery. Get your systemic disease under control before cataract surgery. Understand that the cataract surgery itself can also cause a worsening of dry eye or cause a new dry eye, and that you should be aware about it. use intraoperative measures to reduce the trauma to the ocular surface, postoperative medication protocol to reduce the damage to the ocular surface, and staged approach in cases with cataract and very severe dry eye disease will help you reach a good outcome with your patients. Thank you.
Thank you, Dr. Bhaskar, for an excellent talk. As always, your knowledge is really inspiring. So I have a quick question for you or any of our panelists. Of course, as you very nicely showed, if we diagnose them as dry eye pre-operatively or post-operatively, we know how to treat. But there are some patients who come and while they're on the steroid or post-operatively, they're fine, but after that come back with this chronic pricking or some sort of irritation which they're not able to describe. But it's very nagging for them, and of course they are very recurrent in the OPD. So how would any of you treat that? Do you still call it dry eye, or and what would you do for those patients?
Generally, most of them, if you use a fluorescein stain, you'll probably see that there is still a little bit of irregularity at the site of your cataract incision. And if suppose it's not a temporal incision, say it's a superotemporal incision or a superior incision, or it's slightly more into the cornea, every time that the lid blinks, because of that mild irregularity, it causes the discomfort. So once you understand what the problem is, you probably have to wait and just hold their hands till they get comfortable. You could consider putting a soft contact lens for a couple of weeks till it kind of gets a little bit better. But generally, they are not very, I mean, you also don't want to add on too much of treatment. You probably just want to make them comfortable. But just for them to understand that this is only the problem and it will get better, I might occasionally just give them a trial of a soft contact lens to say, okay, just use this for 2 days. You're feeling a lot better, and it will settle down over the next couple of weeks' time as such.
I think we can go to the next. We can go to the next talk, Anu.
I would like to invite our next speaker, Dr. Sharon D'Souza, consultant cornea ocular surface and refractive surgery, Narayan Netralaya, Bangalore. She will be speaking on dry eye post LASIK.
Good evening, everyone, and thank you to Dr. Namrata Sharma ma'am and AIOS for this opportunity. So I have a very short, quick talk on post-refractive surgery dry eye. We definitely don't, I mean, we're all aware of how prevalent a post-dry eye is in general, and of course, post-refractive surgery. And the reports show that post-refractive surgery dry eye can range as high as 36 to 75%. The good thing is that most of them are in the early months post-refractive surgery and do not continue too long after. But in spite of the treatment post-operatively, some up to 48% can still have some form of dry eye up to 6 months after surgery. Now, of course, it also depends on the kind of refractive surgery that they have undergone, and depending on whether they have LASIK, SMILE, or PRK, it does vary based on that. So about 1/3 of patients who had a normal, no dry eye before surgery did complain after the LASIK that they had some form of dry eye. And this went on till, almost 3 months to 6 months. And 4% of them had severe symptoms for which they were really troubled. Post-SMILE, again, there is some amount of dry eye, but as per reports, it is supposedly lower and it does recover faster than LASIK. Of course, there are varying reports to that as well. And post-PRK, 37% of patients still complain of dry eye symptoms. So let's look into what that can be, because we do know that the dry eye can affect the post-operative, not only the quality of vision, and but also the quality of life. And no matter how good a surgery we have done, it will then, their post-op wow factor is not going to be there. So we want to talk about, just to put this across a case where you've done a refractive surgery and preoperatively everything was normal. But however, they still had persistent symptoms after the surgery with irritation, pain, foreign body sensation, and you do, your dry eye test, and things can be borderline or show some amount of dryness. But, you're always wondering why this happened at all, even though everything was normal beforehand. So what are our risk factors for developing dry eye. Pre-operatively, the most common, of course, is some form of pre-existing dry eye. It may be just a borderline dry eye, but it may be there. So it's very important to check it pre-operatively itself. A female gender is known to have a higher predisposition to dry eye, and that's overall. So it's not different for refractive surgery. For some reason, Asian races have a higher risk of developing dry eye. And of course, when we are having a higher refractive correction, because of the amount of ablation and inflammation, they are known to have a higher risk of developing a dry eye. Intraoperatively, the amount of suction time and the kind of suction that is applied, because it affects the goblet cells on the conjunctiva, the ablation depth, deeper ablation depth will, the amount of nerves affected and the tissue affected changes. Thicker flaps for the similar reason. The flap hinge positioning, nasal versus superior, and we will talk about that. Of course, narrower flap hinge may then cut less flaps, and in surgeries like SMILE, where there is no hinge at all, we may be better off. So what are the possible causes of post-refractive surgery dry eye? As I was saying, a pre-existing any form of dry eye is the biggest risk factor. The next is the corneal denervation, which leads to decreased sensitivity and then some form of dry eye due to that. Now, because there is less sensitivity, we also tend to have a reduced blink rate, and then this leads to some forms of dry eye. There's a change in corneal curvature, and this leads to more tear film instability. And of course, intuitively, we understand that this is more with patients who have a higher refractive correction because of the suction, the teardrops, the eye drops, the amount of light used. All of this can cause some amount of mucin-associated tear film instability. And the last, which is often ignored, is a condition called pain without stain, or a neuropathic cause for dry eye. So an identification of what is the possible cause for the dry eye is very integral. And as with all forms of dry eye, as has been discussed from the first talk, putting the lubricating drops is just like a patchwork unless we understand why it is happening and then customize our treatment accordingly. So we did publish this paper, and Dr. Rishi Swaroop, who is one of our panelists, was also one of our authors, to try and understand what is the best, try to form an algorithm to diagnose and manage this. So as we were talking about the various causes, one of the common ones is the denervation of the cornea. So we understand that we have the subbasal nerve plexus, which enters the limbus from into the cornea, into the central cornea, and both any form of flap creation and the excimer photoablation would result in a temporary partial denervation of the cornea. In SMILE, because there's a very small incision at one place, possibly we would be able to spare some amount of the main nerve plexus. But of course, the lenticule, depending on the depth of the lenticule, we may still damage some amount of nerves. Either way, there's a decrease in the corneal sensitivity, which results in a reduction in the reflex tear secretion. And this is one of the main mechanisms for dry eye post-refractive surgery. The changes to the corneal nerves have been studied, and this is shown in various studies from across the world, where immediately post the refractive surgery, there is a significant reduction in the corneal nerves, which possibly translates to some amount of denervation and less sensitivity. But this does recover over time. So that is very heartening that it does recover over 3 to 6 months. The next cause is the reduced blink rate, as I was saying. Because of the decreased corneal sensitivity, the reflex pathway gets affected, and this results both in the reduced blink rate and also a decrease in the reflex aqueous tear secretions. And therefore, you can have some amount of a mixed kind of dry eye, both an aqueous and evaporative dry eye. The corneal curvature, because it changes the curvature, there can be a lot of tear film instability. There's also a change in the friction between the cornea and the lid, leading to a more unstable kind of dry eye. Pain without stain is something which is much more abstract and difficult to understand. But if you have a patient who you've tested everything for, and everything shows normal, but the patient is highly symptomatic, do suspect that they may have some amount of neuropathic pain, which can happen in chronic conditions and post any surgery of the cornea over time. And their classic feature is a pain without stain. And you can also have microneuromas or increased dendritic cells on the confocal microscopy. most of these conditions, as we were discussing, if it's not diagnosed preoperatively, can have significant worsening post-operative. So when we are planning for refractive surgery or a patient has undergone refractive surgery, understand that the damage to the subbasal epithelial nerves, damage to the goblet cells, and alteration in the corneal curvature are the main reasons for the patient to develop dry eye. The damage to the subbasal results in decreased neurotropic factors, which are released by the nerves, and also decreased corneal sensitivity. The damage to the goblet cells due to suction results in an altered expression of mucin. This results in decreased tear secretion, decreased blink rate, increased osmolarity, because we know there is inflammation on the ocular surface, which is known to happen after any procedure, decreased meibomian gland secretions, and increased inflammation. And any form of dry eye can have inflammation underlying it, and we need to treat it. And all of this results in an unstable tear film and decreased tear breakup time. And therefore, we have a sort of a mixed format of dry eye. So there are tests that we use which can be used to evaluate for all of these conditions. For example, if there's decreased tear secretions, it can be evaluated by a dry eye test, and unstable tear film by a dry eye test. But for the other, kind of features to diagnose this dry eye, we will require some amount of advanced diagnostic modalities like the meibography, interferometry, or some, other tests when it's a more advanced kind of dry eye. The ASCRS give a very nice ocular surface disease algorithm. However, some of those things may not be directly relevant to us because many of us don't use osmolarity or the inflammatory markers directly into our OPD. But I think one of the very useful things in their algorithm is the last box, which is the clinical exam LLLP, which is part of our routine evaluation, where we look at the lids, lashes, interpalpebral surface. We lift the lid and examine the superior surface. We're pulling to look for any lid laxity, floppy lids, fornices. We push to see for a meibomian gland expression, and of course staining to look for any changes on the ocular surface. And once we see if there's any ocular surface disease, we rule in or rule it out. Then depending on the severity, you have to decide whether you want to go ahead with the procedure or not. And this is just to summarize what we've been talking about. But basically, it comes back. The treatment doesn't change in any way. But depending on whether you have a mild, moderate, or severe disease, you decide whether you want to go ahead with the procedure or not. Obviously, if it's a severe dry eye disease, you would avoid refractive surgery in any way. And if it's a mild to moderate disease, you would, take a call. The treatment, as I said, does not change in any way. It is part of our routine management, which we've been discussing through all the various talks. The main idea is to identify it early and treat it as best as we can. Thank you very much for a patient listening.
Thank you, Sharon. I think that was a very comprehensive overview. And who else could give it better? You've done PhD on dry eye. So I think many congratulations for that. Great work. And thank you for a great talk, like always. I think we can move to the next talk, Dr. Anu.
Okay, ma'am. I would like to invite our next speaker, Dr. Anahita Kate, Consultant Cornea and Ocular Surface, LV Prasad Eye Institute, Vijayawada. She'll be speaking on dry eye and immunosuppression.
Good evening, everyone. At the outset, I would like to thank AIOC and Dr. Namrata Sharma for providing me the opportunity to present here today. So I will be discussing immunosuppression in dry eye disease, and as has already been discussed, aqueous deficient dry eye can be broadly classified as Sjogren's and non-Sjogren's ADD. And it is important to identify the underlying etiology because the type of immunosuppression and the degree of immunosuppression will be dictated by what the patient actually has. So it is not easy to form one common algorithm for all the diseases together, but overall, this is the pattern that we can follow. So if we have a patient who has aqueous deficient dry eye, we typically send the patient out for systemic workup to rule out underlying connective tissue disorders. If this turns out to be positive, if it is indicative of a specific disorder, then it becomes a little more straightforward because the immunosuppression is carried out by a rheumatologist. However, if it is negative, then depending upon the degree of surface inflammation, we can start the patient on either only topical immunosuppression or topical with systemic. So let us look at each one of these diseases individually, starting out with Sjogren's syndrome. Sjogren's, as we know, it can be primary or secondary based on whether the patient has associated rheumatoid arthritis or SLE. And for topical immunosuppression, the indication is very similar, and it is dictated by how much surface inflammation that the patient has. And the medications that we prefer are topical steroids and topical calcineurin inhibitors. And what is different is how the systemic therapy is given. So typically for primary Sjogren's syndrome, it is systemic immunosuppression is not indicated for ocular involvement in isolation, and it is given when the patient has extraglandular involvement, either in the form of arthritis or dermatological manifestation. Whereas in secondary Sjogren's syndrome, if the patient has RA or SLE, the patient is immediately started on systemic immunosuppression. So let us look at these three patients. If we see them clinically, all three cases look very similar. All the cases have Sjogren's syndrome, but one patient received only topical immunosuppression, one patient received systemic, while one patient received a combination. And let us see why. So this is the first patient who presented to us with this surface inflammation, had a very low Schirmer's. And so when systemic investigations were carried out, the patient had Sjogren's. But because the patient did not have extraocular involvement, otherwise systemically he was normal, the patient was only started on oral secretagogues along with topical steroids and cyclosporin. And this is the clinical image 6 months later. We can see the patient has a very stable ocular surface. Now, this is another patient. This is second case who again had severe dry eyes, and in the right eye, the patient also had a very significant epithelial defect. So again, a systemic panel was carried out, and the patient was positive for RA factor, and so the patient was started on HCQ and methotrexate, along with topical lubricants and topical steroids. And this is the picture 3 months later. So in patients who present to us for the first time and they're not already on systemic immunosuppression, we can just wait for the systemic immunosuppression to set in and see its effect on the ocular surface, provided that the dry eye is not very severe. And in these cases, topical immunosuppression can be avoided if the ocular surface inflammation is controlled with the systemic immunomodulatory therapy and if the surface staining is okay. This is the third patient. This is the right eye of the patient. The patient came with the sterile melt, and 6 months down the line, the patient had a healed surface, but you can see there is this persistent inflammation. So again, the patient was subjected to a systemic panel, and this patient also had very high RA factor. And so the patient was started on immunomodulatory therapy, but this patient also required topical cyclosporin in addition to the systemic cyclosporin. And this is the presenting picture again for reference. You can see how much inflammation the patient had. And so a dual therapy was required in this patient. And with this therapy, this is 6 months later, the patient did very well. So this is a case of severe dry eye in a patient with SLE. The patient also had keratinization of the upper tarsal conjunctiva, and both of these resolved when the patient was started on oral methotrexate. So when do we give IV immunosuppression? So let us look at again this patient who had secondary Sjogren's. The patient had rheumatoid arthritis, came with this bilateral severe melt. In the right eye, the patient also had infectious keratitis. The patient was given topical antibiotics, underwent amniotic membrane grafts, and was also given IV methylprednisolone 3 doses, 500 milligram, one dose per day over 3 days. And with that, this is 6 weeks later, the patient had redeveloped a very good stable ocular surface and was continued only on oral immunosuppression. So let me discuss a little bit about T-cell inhibitors because they're the most commonly used topical medication in dry eye disease, and they act by preventing T-cell mediated activation of T-cells themselves. So the available formulations, the most commonly used ones are cyclosporin and tacrolimus. These are the other ones that are available in the market. And if we see the pathogenesis of dry eye, there is ocular stress that occurs because of all the surface desiccation, and that causes release of several cytokine mediators. And all of these ultimately result in T-cell activation, which in turn results in the secretion of several factors such as IL-1, TNF-alpha, MMP9, which results in the signs and symptoms that we see in these patients. So the most commonly used medications target the T-cell activation and reduce the inflammation induced by these lymphocytes. So these are the studies which show the efficacy of cyclosporin in dry eye, and overall there is a good improvement in the dry eye disease parameters. But this is not uniform across all studies because the outcome measures that are used are different, so comparison is not easy. Also, cyclosporin is not very effective in treating dry eye because of surgical procedures, contact lens use, and it fails to completely revert the ocular surface back to its original state. And this is seen in around 50% of the cases who receive topical cyclosporin. So this is a table which shows all the meta-analysis which has been carried out, and the results of this are also very similar. The total, this has been seen in nearly thousands of patients. Overall, there is a very good improvement in the symptoms, but in terms of signs, the improvement in the corneal staining is seen in only 50% of the cases. Additionally, topical cyclosporin can also improve the neurotrophic component. It can increase tear production. There is a good tolerance for continuous use up to 12 months. And there is a persistent decrease that is seen in the ocular staining scores even after discontinuation. And this is specifically seen in patients who have used cyclosporin for at least 1 year. But as we discussed, that the improvement in the staining scores are seen in only 50% of the cases. And this was one such patient who did not do very well with either oral or topical immunosuppression. And this can probably be the time point at which the immunosuppression is instituted and the lacrimal reserve that the patient has. So early on in the disease, if it is instituted, the patient is more likely to do better as compared to later on when the gland has completely fibrosed, and so the tear function will not improve. These cases, as Dr. Bhaskar also alluded to, do very well with punctal cautery. So we can see the results over here with, this is just 3 weeks after punctal cautery, there's a very significant improvement in the surface staining. And these surgical interventions should be considered to augment the ocular surface health. So now moving on to non-Sjogren's dry eyes. In Stevens-Johnson syndrome, primarily we manage with topical therapy. There are a few case reports where they have used systemic therapy, but we must consider coexistent pemphigoid or local causes which are causing persistent surface inflammation before we think of adding systemic therapy to a patient who has SJS. In pemphigoid, the traditional step-ladder approach is used, and systemic immunosuppression is the mainstay of therapy in these patients. Typically, a first-line monotherapy can be considered either with methotrexate, azathioprine, or mycophenolate. And if the disease is very severe, a dual therapy can be given, or biological agents can be considered in these patients. And finally, we have graft versus host disease, where topical therapy is considered if there is significant corneal or conjunctival staining or hyperemia. And similar to primary Sjogren's, here the first-line therapy is lotipred or any other topical steroid along with calcineurin inhibitor, because again, this is a T-cell mediated surface inflammation. So now this was a patient who was referred to us for conjunctivitis and chronic conjunctivitis. And if you see, the patient had very low Schirmer's. And if you retract the phonicis, the patient had phonicial shortening. Because of this, we suspected that the patient may have pemphigoid disease. And so conjunctival biopsy was carried out, which was positive for IgA and C3. But interestingly, because we also sent a panel for CTD profile, the patient was also positive for RA factor. And so the patient was started on oral immunosuppression. And what the main learning from this case is that, and we have several similar cases, that pemphigoid patients who have pemphigoid early on in the disease, they do not have very severe aqueous deficiency. So if you see a patient who is a case of pemphigoid and has severe aqueous deficiency, or in this case, if you look very carefully, the patient also has signs of old PUK. These are indicators that the patient should be subjected to a CTD profile to rule out underlying RA or sometimes even SLE. So this is another similar case, a case of pemphigoid who was biopsy positive, came to us with significant surface staining, very low Schirmer's, and the patient again had rheumatoid arthritis. And this is the patient on immunosuppression 6 months later. So although the treatment is similar for Sjogren's and for pemphigoid, the extraocular involvement is very different, and therefore detecting the disease will allow the rheumatologist to monitor accordingly. So last, coming to graft versus host disease. Dry eye is a very important component of graft versus host disease, and usually the patients present to us Initially, in the first 1 year after the bone marrow transplant, the patients are on very high dose immunosuppression. And when this dose is tapered 1.5 years later, if the patients are not treated, if the disease is not detected in time, this is when they start developing severe dry eye. And at this point, the dry eye is again managed with topical steroids, lubricants, and topical calcineurin inhibitors. But there are a few reports where the patient had to be restarted on the systemic immunosuppression and the dose had to be increased. And this has to be done in conjunction with a hemato-oncologist. So to conclude, aqueous deficiency dry eye, we need to understand what is the etiology that we're dealing with so that we can understand whether to give topical or systemic immunosuppression in this patient. If the patient has primary Sjogren's, then the mainstay is topical immunosuppression unless and until the patient has extraglandular involvement. In secondary Sjogren's, the immunosuppression is initiated by the rheumatologist, and we can augment it with topical, or we can dictate the dose of the systemic immunotherapy based on the severity of the ocular disease. In non-Sjogren's ADD, in SJS, again, it is only topical therapy. Pemphigoid, it is primarily systemic, augmented with topical therapy. And GVHD, again, is primarily topical. If required, we can shift to systemic. Thank you, everyone, for your patient listening.
Thank you, Dr. Anahita, for your informative presentation.
Thank you.
It was very comprehensive, Anahita. You covered everything, and it's not an easy topic to do, especially immunosuppression and dry eye. Rishi, would you want to give some comments?
I think this was the best talk I heard today. She covered the topic so well, actually.
Thank you.
And especially, I think you made it very simple for the general ophthalmologists, which are the ones which require systemic therapy, which require topical therapy. And even if they are not doing it themselves, they know when to refer. I think congratulations on that. Yeah, I think there's nothing much to add in this.
I have seen a lot of patients who are just given lubricants, and I've seen OCP over the years only given lubricants and nothing else because they've not been diagnosed. And then, like you said, if you don't diagnose them promptly and don't treat them promptly and correctly, then the whole thing goes into an end stage kind of ocular surface failure, and then you can do little about it. So I think it is very important to not give patients lubricants, but to refer to them, as Rishi also said, appropriately.
Just one point for Anahita and also for everyone is that many of these patients, when you do a panel, you may get RA positive. That doesn't mean that they have, it's not RA positivity of rheumatoid arthritis, because RA positivity can happen it's a cross reaction kind of RA. Yeah. So we don't, at least in other ocular inflammatory disorders, just having RA positivity, let's say you have some idiopathic uveitis. So we don't label the patient as rheumatoid arthritis. I mean, I know you know that. I'm just pointing it out for the benefit of everyone.
I think if these tests come positive, it is red flag for us to refer the patient to the rheumatologist, who will then decide what has to be done. They complete the rest of the panel and take a call regarding immunosuppression.
Okay, I think we move to the last part of the thing, which is again very interesting.
I would like to invite Dr. Somashila Murthy, Senior Ophthalmologist, Cornea and Uveitis, Ocular Pathology Specialist and Medical Director at Shantilal Sangvi Eye Institute, Mumbai, member of the AIOS Scientific Committee and Chair of the Scientific Committee of Uveitis Society of India. Over to you, ma'am.
Thank you very much. So it's been a while, looks like, since I gave a talk on a webinar. I forgot how to share screen for a moment there. And thank you so much to Dr. Namrata Sharma and to the organizers, Dr. Anu and Sharon, for letting me present these cases. And what is really good is that I go in the tail end and my cases exactly follow Anahita's, because they're very similar topics to what she said. So I'm just going to present the cases. She's made my job very easy. And then everyone, I'm sure, will be looking forward to going home. So it looks like even I may move city or country perhaps, but the cases will not move and they keep coming. I've seen this very similar cases that I used to see in Hyderabad as well. And I've seen them along with Dr. Prajakta, my colleague, with me. So the first case is one aspect that we couldn't cover, and I thought I'll cover through this case, is what happens when the patient with severe dry eye actually gets microbial keratitis. This is one such patient. And she has secondary Sjogren's, which Anahita has so beautifully explained, is when the patient has a primary disease like rheumatoid arthritis in her case. And when she first came in, she was kind of okay in the sense that her right eye, she was doing pretty well. In the left eye, she did have central or inferior central staining. And the left eye, she had poor vision. In the right eye, she was doing well with 20/50. So she was using lubricants, low-dose steroids. She was on Folitrax and tofacitinib from her rheumatologist almost for the past 30 years. And her history was very eventful. She had some kind of systemic breakdown. In 2019, she had got pulse therapy. Then her cornea had a sterile perforation in 2019. And after that, she got better. She underwent cataract surgery and also DCT. She also had undergone a conjunctival biopsy, which was the panel was negative. And since then, there were at least 3 documented episodes of corneal melting, which somehow recovered. And after that, she stabilized. And when she saw us, she was using scleral lenses, and at least in her right eye, was seeing well enough to manage. But 2 months later, she came back to us. She had symptoms since 3 days only. And what I'm showing here is that not only does she have the cornea seems to be infected here, there's an infiltrate, but even on the conjunctiva, there was this nodule and swelling over there with a pus point. At that time, it didn't strike me, but later I realized that what could have been causing this infection. And we did scraping from this area. We got gram-positive cocci, and which also grew streptococcus. So here I have a patient with severe dry eye, secondary Sjogren's, bad ocular surface, and has this particular bug, which was working, for which only vancomycin would work. That's what the microbiologist told us. So we used that medication, and luckily we could get the patient to heal. The right eye continued to do well. So unfortunately, just the very next month, now the right eye was in trouble, and this was her only good eye, only seeing eye. And she had, it looked like what was a sterile melt, but just starting, edges were showing, we were suspecting infection. So we did scraping and microbiology. Luckily, this was sterile. So just cutting to the chase, here we send a scleral lens for culture, and that grew multiple organisms, which may or may not be the cause of this ulcer. So we discontinued her scleral lens, and we stepped up her systemic immunosuppression because of the sterile nature of this melt. And meanwhile, her left eye just continued to sort of get better very slowly with scarring on the cornea as well as conjunctiva. So this was the report of the scleral lenses. And eventually, after a long battle of several months, we got her to a stable condition. And at that point, we realized that although she had undergone DCT, but this time we thought of syringing her. And when we did syringing, we saw that there was a lot of regurgitation on pressure. So regurgitation on the syringing. So what it means is that just undergoing DCT is not enough. Some of these patients have residual sac infected tissue. So the patient underwent another DCT for both the residual sac for both the eyes, because this was the focus of infection for her. And after that, she stabilized, and we went on to do multilayered amniotic membrane for the right eye. It actually perforated subsequently, and we went on to do multilayered amniotic membrane for the right eye. And now she's doing, it's just touch and go. She has one good eye. So she's back to using scleral lens now for that eye this month. So that was the first case, which was the difficulty of having microbial keratitis. And the take-home message from that is, even if a patient has undergone DCT, or even if often we feel that because the puncta are blocked, so we don't have to worry about the sac. But if there's an infected sac, it still needs to be excised. Coming to my second case, this gentleman, 59-year-old, and he said that his right eye was always like this. So he had dermalized ocular surface since some conjunctivitis episode in childhood. They had attempted ptosis surgery for the right eye, but that didn't work. And when he came to us, he had almost like a CPEO or a very severe aponeurotic ptosis. And the left eye, he had both punctate, superficial punctate keratitis, and his DATs, we couldn't do anyway, but he did have severe ocular surface disease. As you can see that he had a lot of staining on the left side, and also he had a lot of concretions. So we didn't know exactly what was the etiology in this particular case. There wasn't any obvious conjunctival scarring or fornical foreshortening that we could consider diagnosis with OCP. And we did investigation panel, of which just talking to you about the prominent tests, that both RA, CRP were negative. But we antibody in the A&E profile, And later, when we investigated, when we looked at this, it is apparently associated with certain immune-mediated disorders, one of which could also be ocular inflammation. So we have categorized him as having a sort of an ANA positivity and extended ANA profile, showing this particular molecule being positive for this patient. Subsequently, we did punctal cautery, and he was always on lubricants and topical steroids. And we then worked up and started the patient on immunosuppressants, and he's doing extremely well now after we have started immunosuppressants for this patient. So this was one case, exactly as Anita said, based on both the ocular and systemic component and also the stake. So how high, what are the stakes that we're looking at? Here's a one-eyed patient. So even that would be one more reason for me to start using systemic immunosuppressants much earlier. I think this is my last case, a case of SJS, and the patient also has seropositivity. So as Anita once again said, that Stevens-Johnson syndrome patients can have varying spectrum, and this particular patient had query due to antibiotics developed Stevens-Johnson syndrome, was well documented. There was no doubt about the primary diagnosis as per the patient, and HIV positive since 2007, even before the Stevens-Johnson syndrome. She had also undergone symblepharon release and AMG 2 years ago for the right eye. Luckily, her left eye was really in good shape. She had 20/20 vision. There was just minimal keratinization like this in the upper lid margin and no SPKs. So for the left eye, we with actually a wet ocular surface. So we prefer to observe. In the right eye, you can see that she had these trichiatic eyelashes, and these we are holding the lid up. So, but in the normal position, it was rubbing against the cornea, causing the central defect. So all that we did was just help the epithelial defect heal, and also did electrolysis. We placed a BCL for a short while. So we stabilized her right eye so that it's like a reserve eye. It's SJS, so we are not proceeding at this point to doing anything further. And she's managing well with her left eye. So we are observing this patient, and she's on regular follow-up. So this is, since she's seen us, this is 6 months later after the punctal cautery. It's still holding good. So exactly as Bhaskar and all the speakers here have highlighted, that that's one almost sort of a magical solution that we can do for many of our patients if the puncta are still open. So that's all I have for my presentation, and I acknowledge once again Dr. Prajakta, who helped me put up these cases and co-managed with me. Thank you for this chance once again.
Thank you. I think, Somshila, those were again very difficult set of cases, but managed really well. And they are best referred rather than trying to do it yourself. So, any final comments from the panelists?
I have a question for Dr. Somshila. In the last case, I thought the lower lid showed some margin keratinization in the bad eye. So would that have benefited from a mucous membrane graft?
Yeah, we could do the mucous membrane graft, but then
I meant the right eye, not the left eye.
Correct. I know. We just held on doing nothing much for the right eye. So in fact, it was not really, a patient was fine with whatever we do, but we just held on doing anything for the right eye.
Because that epithelium in the right eye looked more like thickened epithelium, not exactly like a conjunctivalized epithelium. And sometimes if you improve the kind of environment, it kind of becomes quite normal, is what I've...
Yeah, I think I completely agree with you. If I remember, if I guess you've seen the last picture very well.
Yes.
And yeah, that's a really good point, and maybe we'll consider it when she follows me.
Yeah.
The patient is happy, so we've just left her at that.
Paras, any comments from your side?
No, in fact, the whole topic was covered comprehensively so very well, starting from basics to what to do, what not to do, and sharing all the difficult cases and role of immunosuppression. So I guess it is very well covered for the day.
Sharon, I think we can thank everyone.
I had one, may I speak? I had a comment for Dr. Sharon's question. Ma'am had asked that whether prophylactic lubricants should be used with anti-glaucoma medications. So for that part, ma'am, I would like to answer that prophylactically, we never prescribe lubricants, because again, lubricants will have preservatives, and that also will lead to all these problems. And the second part of the question was like whether this will affect with the anti-glaucoma medication. So in the very early stages when all these medications were made and lubricants were being prescribed, actually the BAK is the one which actually disrupts the tear film, and it allows the penetration of the drug. So the drug company people or maybe the ophthalmologists were very happy in the beginning, but if you look in the long run, it is not a good thing. And with the upcoming medications like nanotechnology and all these medications, we don't need BAK anymore for absorption. Thank you, ma'am.
Thank you. I think
Great,
that is useful and insightful for all of us as cornea surgeons, because that is what we would tend to think, that with anti-glaucoma, you prescribe a lubricant also. So thank you, everyone. I think we've had a great webinar. I would particularly like to thank Dr. Sharon and Dr. Anu Malik for coordinating it, all the speakers, panelists who sat through it. And I think, like Rishi said, it started from basic, but the final blow was very advanced. So it covered from basic till advanced with all the case presentations. Thank you. I would like to thank CIPLA for sponsoring this webinar, and I would like to thank our audiovisual team, particularly Mr. Sunil, who week after week and for years together has now been doing webinars for All India Ophthalmological Society, which are absolutely flawless. So thank you, everyone, and hope to see you again in some other platform, on some other webinar or physical meeting. Thank you so much. Thank you, Rishi.
Thank you, Dr. Namrata.
Thank you, everyone, and thank you, Namrata ma'am.